Okay, well, good afternoon. Thank you all for being here on a bright and sunny Friday afternoon. And it's a delight to welcome you all here to today's Dean's Lecture. Now, I've been looking forward to this discussion with Dr. Perlin for many weeks, for reasons that I'll describe in a moment and reasons that you'll hear when John speaks to all of us and discusses his work with us this afternoon. You know, this is a very exciting time at Stanford Medicine. It's an exciting time in medicine in general. There are so many advances that impact patient care that are coming out of Stanford and out of organizations like HCA. You know, just last month, Stanford's Gregory Alberts announced exciting news about how new approaches to removing thromboembolism and stroke, how the time period, the time window that we had thought had to be followed in order to successfully alleviate a thromboembolic stroke, that actually that time period was too short and could be expanded. Dr. Albers led a 38-center study to establish those criteria, and within just a matter of weeks, the AHA had implemented it as a guideline across hospitals around the country. And the impact of this research that's done at multiple centers, continues to expand. And I'm particularly pleased this afternoon to welcome Dr. Jonathan Perlin, who throughout his career has led these sorts of transformative, impactful studies that have truly changed the course of care in so many different areas. You know, at every step, Dr. Perlin has embraced the concept and the notion that information technology applied to healthcare in a thoughtful, reasonable, considered way, that IT can really change for the better the safety, quality, and value of the care delivered. Dr. Perlin currently is the President of Clinical Services and the Chief Medical Officer of the Nashville-based Hospital Corporation of America, where he oversees care and quality at 177 hospitals, or I guess it's 179 now, and over 1,000 surgical outpatient facilities around the country. Prior to that, Dr. Perlin had been, in effect, the Chief Medical Officer and lead for the entire VA healthcare system. It was during his time at the VA that the VA adopted a uniform medical record, and in so doing, a uniform electronic medical record, and in so doing, dramatically improved the quality of care being delivered throughout the system. Dr. Perlin has been the primary lead behind a number of impactful studies. He's going to talk about, I think, some of those today. One that really stands out in my mind is his focus on sepsis in the ICU setting, in a now classic New England Journal of Medicine paper showing the approaches that need to be taken to dramatically reduce the instance of methicillin-resistant staph infections in the ICU setting. And because of this study and because of that work, I know that thousands of lives, not only in the HCA system, but across the country and the world, have been saved because of the evidence-based guidelines that emerged from that study. So Dr. Perlin has received numerous awards for his work. He's broadly published. He continues to serve on a number of national committees, in particular a committee that is working with the VA on the implementation of the new electronic medical record system, the Cerner system that will be rolled out in the VA system. So please join me in welcoming this afternoon Dr. Jonathan Perlin. John?
Thank you. Thank you. Thank you. Well, good afternoon. Delight to be here with you. Dean Minor, thank you very much for that warm welcome. It's great to be here. It's a privilege to be with all of you. Great to see you and many friends from lives past and present. And your introduction was absolutely perfect in terms of what I wanted to talk about in really about 12 to 14 minutes before our conversation. So I've entitled this, The Perpetual Motion Machine, a metaphor for learning and improving health system. And here you see a spinning wheel, and I'll come back to the rationale for this. But I think all of us grew up with the idea, if we were interested in science, that there could exist a perfect system where the energy put in that system would not dissipate, but keep that system running. And I hope you see that by the end of the 12 or 14 minutes that there's a metaphor that if we use our electronic information correctly, we actually have something that utilizes the energy to generate new energy, new understanding, and learning and accelerating the improvement of healthcare. So here we are in the post-meaningful use era. 98% of America's hospitals, 95% of physician practices are computerized, and we can do the transactions of healthcare, but are we learning? Now, this was a question that was driven home to me in my time in VA. Dean Minor alluded to that, but take yourselves back to 2005. It was the time just after Katrina. And as CEO of the VA health system, my boss was the Secretary of Veterans Affairs, and his boss, of course, was the President. So I received an invitation to go across the street to the White House. They had a special guest there. And would I show this special guest what we were doing with electronic health records? And I was able to demonstrate to this individual that whether a veteran displaced by Hurricane Katrina relocated to Washington, D.C. or Washington State, you could actually follow that individual. The individual was nonplussed. He looked over and said, well, that's nice, but why aren't you learning? Well, Bill Gates was already thinking ahead about big data. But in 2005, you couldn't go down to your local office supply store and buy a multi-terabyte hard drive for under $100. It took all the power in the world just to run a single hospital. But he anticipated that future where those big data would create the capacity for learning at speed and at scale. And so I want to share a couple of these studies and what it bodes for the future in terms of even accelerating this learning equation further as we advance up the analytic hierarchy from the usual approaches to statistics, the creation of data and descriptive statistics, how many, how much, what happened, to diagnostic statistics, why did something happen, up even further to predictive, what's going to happen, to prescriptive, what should we do about what's going to happen. And we may not quite be at the point where we have self-driving car systems that are automated in the care of individuals. But these are the opportunities if we harness the energy that's part of that equation. So the notion of perpetual motion machine was that the energy applied to the system would reciprocate and that every cycle of the wheel would go right back in and that wheel would never stop. I think that's a pretty apt metaphor for the opportunity that we have today with electronic health records. In fact, if you look at this motion by analogy, every time we have a care event in the computerized world, we have what the technologists call a data exhaust. We capture those data, but if we're smart, we process this data into usable knowledge. We apply those analytics so that we can bring it back to the point of care wisely, and in that process, personalize and be more precise in the delivery of healthcare when that occurs. As well, we want to bring it back into the system for improvement of the system itself. If we do this, we don't allow the data to escape that full cycle and just dissipate into entropy as heat, but in fact illuminate the system so that care informs care as we bring the data out of the clinical encounter to capturing it, and care improves care as we bring it back to both the system and the individual patient as part of a learning health system. Well, Dean Minor alluded to one of the really best use cases, I believe, are early out for learning at speed and at scale. And I think this group likely knows the tragedy of healthcare-associated infections in the United States. 1 out of every 20 patients in America's hospitals, when they leave the hospital, if they're fortunate enough to leave, leaves with something they didn't come into the hospital with, a hospital-acquired infection. That translates in real numbers to over 2.1 million individuals today. And of those individuals, sadly, about 80,000 pay the ultimate price. They give their life because of a hospital-acquired infection. Just to put in context, that 80,000, that death toll is actually more than the aggregate of motor vehicle accidents, HIV, and breast cancer combined. And beyond the tragic human cost, there is an economic cost as well. And MRSA, methicillin-resistant Staph aureus, accounts for about 1/4 of the infections. So the question was, could some of the work that we were doing in HCA, that we had actually taken out of VA, be used to study and understand what truly is best practices. In fact, there were two other approaches to care that I'll tell you about in a moment that were really in theoretical equipoise with the approach that we were taking. And the question was, could you actually envision a real-life health system as a learning health system to accelerate the understanding of what approach might work best? Well, as Dean Minor said, we were blessed with a fairly large health system, 179 hospitals, have today about 34 million patient encounters every year, deliver about 250,000 babies, and so the opportunity to learn at speed and at scale is very real. And so the opportunity occurred to embed a 3-arm comparative effectiveness study, cluster randomized by hospital. So let me unpack what I just said. It was pragmatic research. It wasn't done in a sort of single-purpose research unit. It was done in the course of day-to-day care. It was comparative effectiveness. It was going to compare the 3 different competing approaches. The notion was to randomize by individual hospital as opposed to individual patient, because that would make it a whole lot easier to implement. And oh, by the way, if you're studying infections, you wouldn't want one approach of one patient that could potentially, literally, contaminate or infect the patient next to. So what were the 3 approaches and how were they distributed? We ultimately had 43 hospitals in this study, and they, over the course of 18 months, enrolled 75,000 patients in 3 arms. The first arm was what had been the standard for reducing MRSA. Now, the literature for MRSA wasn't terribly strong, but there was empirical evidence from around the world. Why was it? In countries like the Netherlands and in Scandinavia, that the rates of MRSA were much lower than the rest. Turned out it was in those countries when patients came in with repeated hospitalizations or other healthcare encounters, they thought those patients were at highest risk for MRSA. And so they'd do a nasal swab, and if the swabs were positive, they would isolate those patients. It was called targeted active surveillance. And that's the approach that we had used, and we actually brought our standardized infection ratio, the risk of infection, well below 1.0. In fact, a 4-fold decrease in ventilator-associated pneumonias and other things. And that was the approach that we shared. But brought to our attention by the lead of one of the infectious disease services at CDC, John Jernigan, a terrific colleague from Harvard, Rich Platt, were 2 other approaches in equipoise. He said, well, that's the base case. What if you actually had a second arm, where you actually did the screening, the isolation, if positive, an antiseptic chlorhexidine sponge bath, plus nasal mupirocin, antibiotic nose drops, or here's a really radical idea. What if, instead of wasting the time to screen and then there's a period of time before the cultures are back, what if, on admission to the intensive care unit, you just went with the sponge bath and the nose drops to begin with? What would be best? Well, 18 months later, 75,000 patients, 280,000 patient days later, here's the answer. On top of all known best practices, every bundle out there, in an environment where the infection rate was already lower than expected, the rate for avoiding all potential life-threatening bloodstream infections was 44% lower, and MRSA specifically 37% lower. The number needed to treat for every 99 patients to colonize 1 bloodstream infection was avoided. You see our research partners there. I mentioned Rich Platt and the terrific Harvard team, which Grace Lee here today was part. CDC, of course, Agency for Healthcare Research and Quality was funder of the study. Our organization, all of our hospitals, all the hospitals that were participated were part of HCA. Rush University, where the lab samples were run, and UC Irvine. And it came out, as was mentioned, in the New England Journal as a fairly prominent paper. And that's a terrific headline, but I want to give you another headline and another sort of comparison. So another really important 3-arm comparative effectiveness study occurred between roughly 1990 and 2000. And it looked at then, I know this can be hard to believe for some of the medical students, 2 new classes of antihypertensives, ACE inhibitors and calcium channel blockers, against the tried and true thiazides. And the endpoint was not just did it control blood pressure, but importantly, did it block really bad, important long-term outcomes, coronary artery disease progression, and heart failure, and of course, mortality. Well, I just mentioned this was a 10-year study. The largest arm was 15,000 patients. It enrolled 33,000 patients overall, not 75,000. It took 10 years to amass the data for the endpoints, and cost $80 million, not $3 million. I think the other important headline of accelerating learning at speed and at scale is this. That study that I just shared with you, the reduced MRSA, Didn't take one hospital 64 years. It took 43 hospitals 18 months. And this is really the magic of information at scale. We can really accelerate learning. The other half is closing the loop. The standardized infection ratio is the ratio of observed infections to expected infections, so lower than 1.0 is good. What you see here is that we actually put our own findings into practice. And while we didn't get the 44% that the study said we'd get, we were pretty happy with 42% reduction in all-cause ICU bloodstream infections. Our colleagues at Kaiser Permanente actually did an econometric study, and it showed that for every 1,000 patients that were decolonized, the health system writ large saved $170,000. And as I mentioned, over the next 2 quarters, we got the same result across all the remaining hospitals in the HCA system. So this is really important in terms of closing that learning cycle, and thus the graphic that's up there at the top about applying back care, improving care. So the first half was care informing care, the second half care improving care. Okay, it's 2018 now. How do we really take this to real time? That's wonderful that we can do that as a prospective study. But how do we actually build the architecture so it can always be learning, so that it can be more like that perpetual motion machine? Well, everything, of course, starts with a care event. We envision the electronic health records as sort of like the, if you'll excuse the expression, the Intel inside. We actually view that as part of the ecosystem, not the entire ecosystem. So we prepare that and procure the data from that so that we can capture it and process it into organized information, and in turn use advanced analytics, data science, knowledge management to really develop knowledge that can be brought back then to the clinical encounter and applied in a user-friendly way to very much app-like devices and inform the next iteration of care, as well as be brought back into the system to support many dashboards and alerts for system improvement and close that virtuous cycle of learning. How much data has gone through in this process of care informing and improving care? Well, our chief data scientist actually did a little comparison for us. And he said if all the written material in the Library of Congress was equated to the mass of the moon, 10 terabytes, and everything that we think Google holds was equated to the mass of the sun, and that's 15 times 10 to the 21st power, we're somewhere between Saturn and Jupiter in the petabyte range, which is 10 to the 18th. And as of the end of January, I just was kind of interested in this. We actually have about 107 million or 106 million discrete encounters and about 38.5 million discrete patients in this data set in which to accelerate learning. How are we doing that? Well, we talked about the reduced MRSA study at the very bottom there, and this plots over time the number of patients enrolled, the number of hospitals involved, and the cumulative number of patients. But the NIH actually came back to us with the ABATE study, and perhaps in conversation, Dean Minor, we can talk about it. But they asked, most patients aren't in the ICU, they're in general medical and surgical units. Will this work? Is this important? And then, of course, we have a real-world epidemic of hospital-acquired infections, but there exists a theoretical risk of resistance to mupirocin, the nasal antibiotic. And the question arose, don't we have an obligation, a responsibility not to invite further resistance? Shouldn't we try to find something against which resistance is not apt to emerge? And so, working again with Rich Platt, John Jernigan, the same teams, we're doing another study that would substitute, instead of mupirocin, a head-to-head comparison study with something called iodophor, which would be essentially a chemical antiseptic. So ABATE study ultimately involved almost 700,000 patients, and to have the power that necessary for what's called the swap-out study with iodophor, we need 120 hospitals and 1 million patients, and we're excited about both, and perhaps some more discussion later. But let's switch to real time. Let's say that you are the hospitalized patient. What would you want from the ideal clinician? A perfect clinician? Well, you probably want their full attention, 24/7, 365. You want them aware of any change in vital signs or lab results or even attentive to your preferences. You want them entirely connected. You want them endowed with full knowledge of your condition. In fact, you'd probably want this cyborg nurse as your provider. But that's really a little overwhelming for the individual. What is it that you want that person to do? you want them to be aware of all of the information, especially if you're a complex intensive care unit patient with multiple feeds of data and multiple orders in effect at any given moment. How many? Well, it's been suggested that at any given moment in the average, and that last patient was decidedly not average ICU, there are about 1,000 new data points every hour. There are about 300 orders in effect. Psychometricians have demonstrated that we humans can manage 7 variables simultaneously. What does that mean in terms of the capacity to think about the variations or the permutations of all of these simultaneous variables? Well, 7 variables is pretty good. There are 7 factorial combinations of 7 variables. Some of you probably have already calculated that in your head. I have all confidence here at Stanford that you've calculated 7 times 6 times 5 times 4 times 3 times 2 is 5,040. Okay, who's calculated 300 orders, 1,000 new data points, 1,300 factorial here? Any guesses? Let me give you some choices. 100,000, a million, a billion, a trillion. Higher. Good person who said higher there. It's the head spinning. Look at this number, 3.16 to the 3,500th power. I think that's more than the finite number of particles in the universe. We obviously can't manage that simultaneously, but as Dean Minor alluded to, this is how we're bringing it back to sepsis. Sepsis, for the infectious disease folks, obviously an overwhelming infection, but for everyone else, sort of a total body failure, and time is essentially life here. The state of the art is to recognize the inflection point where the patient really begins to deteriorate. In fact, that's been the basis of the National Stop Severe Sepsis program. Ladies and gentlemen, that would be sort of like having a national Stop Severe Fire program when we respond when the flames are coming out of the top of the building. Wouldn't we rather sniff smoke? Well, of course we would. But the state of the art is to recognize that point of inflection. Not by using prediction, but actually training up algorithms to recognize the data that clinicians would identify as important at the moment it's created. The computer actually allows us to move the time of sepsis identification compared to best clinicians back 18 hours with 50% greater specificity, meaning that the team is attending to those patients with the greatest need. If you actually go to Predictive, and by the way, gains 18 hours, important because we know that every hour of delayed recognition of sepsis equates to somewhere between a 4 and a 7% increase in mortality. If you actually do go to prediction where you don't have extant data but are predicting what's likely to happen, you retain the 100% sensitivity but actually are only 20% more specific. And what's exciting about this is that this being a plot where the darker greens are the correct identification of sepsis, we know that this unnatural distribution is not a distribution of the natural phenomenon of sepsis. Sepsis is not occurring just at shift change. Sepsis screens, on the other hand, and consolidation of data are occurring on the shift change. But what if you take that data exhaust from the patients in the ICU, the labs, the patient movement, and the orders, and actually process that in that analytics warehouse, as I mentioned, the vital signs, et cetera, well, then you get an entirely different distribution. Looks much more like this, and sepsis is then recognized not approximately 7% of the time within the hour of onset, but at about 94% of the time, I'm sorry, 97% of the time within an hour of onset. Okay, so you've now got a robust signal that sepsis is occurring. How do you get it back to the care provider at the front end? This is where the system really has to come together to get the right information to the right individuals caring for the patient in the right manner that they can make an effect. And here, this is why we've actually put the intel inside and have portalized things so we can pass a message back on a smart device and actually with an alert that this patient is getting in trouble and reorient care. Using the Stop Severe Sepsis and this approach, year over year and against already better than average performance, have saved a number of lives. And to me, who's made a career in patient safety and quality, I was just reading an article about this cruise ship and doing some math. And this cruise ship carries 5,500 passengers, and that 3-year benefit in terms of patients who got to go home, see in a new year, welcome a new grandchild, celebrate a holiday, et cetera, was about 5,500. And this is why fundamentally this is so important to all of us in terms of saving lives. Let's take it one more step up the analytic hierarchy. We were working with structured data, those things that were computable. What if you want to begin to work on the majority, 70 or 80% of the medical record that's text? How do we actually make sense out of simultaneously both the computable structured data as well as the textual data, the unstructured, to read and understand and extract not only facts, but patterns of facts and resolve those facts into similarity and mapping of similarity and reasoning in that similarity so that we can understand relationships in such a way that it would be very similar to what humans would do if they had knowledge of those facts. And this is the notion of really beginning to apply the artificial intelligence. Why so important? That graph of ICU orders could very well have been applying the genomic or polyomic information to our clinical encounter. It could be equivalent to looking at the molecular fingerprint of a tumor in cancer clinic, where by necessity we've been lumpers, not splitters. And two patients who appear nominally the same, they both have breast cancer, colon cancer, et cetera, with a little electronic support are really quite different. And in fact, we tell you about what we're doing in this regard to be able to identify patients earlier. We've trained up an algorithm to read path reports on image reports and the like, and help get the patients to earlier and timelier therapy. Now, this is actually not making the initial diagnosis, but it is actually categorizing the diagnosis from path reports rather than leaving that to a human process. And so using natural language processing from the reports and additional analytics, we've actually taken the process from being very human-based to being very automated. And in fact, what used to take in this first month pilot 2,400 hours roughly has been brought down to 106 hours, or approximately the same as hiring 118 cancer navigators. But most importantly, for these groups of cancers, GI cancers, breast cancers, lung cancers, et cetera, things that deserve situations that deserve timely care, we've been able to provide to patients timelier care, greater patient engagement, to reduce risk for misdiagnosis, and better outcomes particularly for the time-sensitive conditions. Well, let's take it one step further, and this is to use the natural language processing to avoid misdiagnosis. It's hard to believe that almost 20 years ago, the seminal report, Error is Human, came out. The most recent volume was less compellingly titled. It was called Improving Diagnosis in Healthcare, and had to do with the issue of missed and misdiagnosis. Beyond it being the #1 reason for lawsuits in the emergency department, it's a profound problem, and it's difficult to measure what didn't happen in a situation because there are very few markers of that. But I can assure you in closing that this is a situation that's intensely personal to me. One of my favorite cousins had an accident and had a shoulder CT to see if the pain that he was continuing was from that accident. In fact, his CT scan report came back with a text that said, no fractures, et cetera. What it did mention was some sort of bland text about density, apex left lung, and bears follow-up. It didn't say cancer, didn't use the word tumor, and unfortunately, in the environment he was in, it didn't ring any bells. It obviously should have. So we did a study here with natural language processing, 13 ERs across 3 major medical centers, and during the 13 months of the study, 3 ERs, 13 months of the study, 33,000 CTs roughly, and the performance of the computer was compared to the performance of well-trained radiologists, and both identified approximately 1,043 patients with potential incidental findings, and both based on the computer's ability to distinguish the difference between tobacco farmer and tobacco user, and to understand the import of certain words that aggregated with bad outcomes like nodule or density or shadow or bears further exploration. We're able to identify 55 that were worthy of biopsy. And among those 55, there were 28 cancers, and among those, a third were early and curable lung cancers. And so we see this as the ability to really instantiate the learning health system into care, in this instance providing early diagnosis and potentially even curative therapy, but preventing the tragedy of misdiagnosis. But we see it as the instantiation of that perpetual motion, the desire to be able to capture the energy that we're putting into the system anyway through the electronic health record, but use it in a reciprocating process, not to be dissipated as heat, but really to eliminate patient care improvement and system improvement as part of a learning health system. A number of us in this room have been part of the learning health system work of the Institute of Medicine or National Academy of Medicine, which in 2007 offered this definition that a learning health system is designed to generate and apply the best evidence to drive the process of discovery as a natural outgrowth of patient care and to ensure innovation and quality, safety, and value in healthcare. I love to do this because it leads to much better outcomes. Like you all, as professionals, we live to a mission. My organization's mission is the care and improvement of human life, and we see this as our contribution to the improvement of human life. So let me stop there. I look forward to our conversation. I hope I've whet your appetite for the future of the value of electronic health records in helping us learn and improve at speed and at scale, and so thank you very, very much.
Well, John, thank you very much for that informative talk, also very inspiring talk. What do you think, just here to start out, what are the big challenges we have to overcome in order for electronic health records to achieve the vision that you just articulated, that is to really support a learning healthcare system, to support the delivery of higher quality care, and in so doing, to get physicians and patients more engaged in the information that can be gleaned from an electronic health record?
Well, that's a great question, and we really need to have a network effect. Is that this amount of data you need to learn at speed and at scale comes from more than a single institution, and so interoperability is really key. And so forming networks, that's said the value of a network increases with the value increases with the exponential of the number of nodes in the network, so we find the value similarly allows us to answer questions that wouldn't be possible to a single institution. So for example, there's an entity called PedsNet, which allows children's hospitals to look at rare diseases or rare manifestations of common diseases, for that matter, by virtue of having a network where they can study things with sufficient scale. It's the era where we know that randomized controlled trials are incredibly important. They remain the gold standard. They're also remarkably expensive. What we don't hear about are the numbers of trials that don't get published because they didn't work. I predict that there's a day when trials will not go forward unless you've done a digital representation of that trial to make sure that you have an adequate number of patients. So I think we need that last mile of interoperability. We need to have the network effect. From a practitioner standpoint, we need to have a little bit friendlier systems. And from a patient perspective and a social perspective, I think we need to embark in a dialogue about how we should think of health information as a common good and not worry quite as much about all of the aspects of privacy, because we're really missing an opportunity to make a good on the investment in healthcare that we make as a society. It's been interesting. In my time in VA, there was some fairly challenging or charged work. But we went out to veterans. We asked the wrong question. We asked them, if this will help other veterans, do you mind sharing your data? And they said, you don't have to limit that to veterans. You don't have to limit it to citizens of the United States. If it helps other individuals, we're all in. Patients with chronic illness have a much higher premium on health information than they do on privacy. And so I think we need to move that dialogue forward as well.
Great. Under the heading of digital health, we're seeing advances in analytics, as you described, the use of AI to extract information and correlations from these treasure troves of data that are sitting out in electronic health records. And in parallel, we're seeing advances in consumer-facing devices, from the Apple Watch to the Fitbit, and just a host of things that are about to become available and relatively inexpensively. How do you see those coming together, and how can when you and I had lunched before your talk, you were mentioning that the Fitbit came out just after you had finished your work at the VA, and then how you probably would have incorporated it into care delivery had it come out a little bit earlier. But how can we better leverage these consumer-facing devices and make sure that they're interfacing with our overall picture of health in the patients for whom we're providing care?
Dean Minor, that's a terrific question. We all observe the phenomenon of white coat hypertension, and so all the real data is not restricted just to the clinical setting. What we really want are a rich set of data that reflect the individual's life and their exposures and experiences. What the Dean is alluding to is that in VA we had early on the opportunity to give veterans with heart failure digital scales, and if they had a sudden increase in weight, then we knew it wasn't that they had a big dinner. It's that they probably had an event occur and that they were tipping into heart failure. And so rather waiting for them to crash and burn and be in the emergency department and need to be intubated and diuresed, instead you could intervene often as an outpatient with more modest but timely intervention. Well, the future is all about the mashup. I would have loved to have been able to give those same veterans an exercise meter, a Fitbit or the like, an Apple Watch, whatever, and noticed a deterioration in the change or cadence of their activity. I think that would have informed us. What a wonderful way to actually look at the real-world outcomes. Certainly interesting to watch my family members who have hypertension and to get a very different picture from the ambulatory and real world, their free range experience as opposed to their in-office experience. When I think of childhood asthma, the opportunity to mash up all sorts of different forms of data, the environmental data, the atmospheric conditions, the pollution in a particular day, the meter dose inhaler with a Bluetooth connector that can come in and practitioners can track a child who has increased frequency of use of that, and bring all those data together with the formal health setting data, you begin really to get a rich picture of the information. You also begin to get a rich picture of information about things you didn't anticipate to study. So why is it that I respond well to naproxen and I don't respond well to ibuprofen? Well, it's not a question of preference. It's not a question that one lasts 12 hours, the other has a shorter half-life. There's something there when you begin to bang up the exercise tolerance with the polyomic information. You probably will find that things that we used to say, oh, it just didn't work, antihypertensives, analgesics, whatever, actually have a foundation in biology that we can elucidate. And so for all of these reasons, I think the consumer-facing devices, the patient-reported outcomes in conjunction with polyomic information and the formal health record are really the magic for the next era of data science and improved healthcare.
Just one more question, then we'll open it up to the audience. But you've been consistently throughout your career interested in policy and the role that policy can play in improving healthcare and the delivery of healthcare. If you could have anything you wished in terms of implementing policy, what would be the top 2 or 3 policies related to health and healthcare that you would like to see implemented in our country today?
Well, great question. I think there's a lot that all of us would like to say, but I would like to actually, if I could do one thing, it would be to reframe the policy debate. I would reframe it from some of the rhetoric that's occurring now that's polarizing and not helpful to a single question. How can we achieve the greatest health for our society, the best care for any individual patient at the lowest cost? I would hope with those 3 things we could frame a rational discussion that's based on economic policy and science, best health, best care, lowest cost, best value for our entire country. And oh, by the way, a little data point. During my tenure in VA, in the late 90s, there were approximately 93,000 beds in VA and only 200 clinics. And there wasn't a lot of preventive services. And so when veterans came to identification with colon cancer, it was almost always transmural or metastatic. Terrible. Not safe, not effective, not efficient, and certainly not compassionate. As preventive services became the standard within VA, by 2004, majority of veterans identified with colon cancer using the VA health system was almost always a polyp or just marginally into the colon wall. Not only was it more compassionate, safer, and more effective, it's just a whole lot more efficient to take care of individuals with localized disease than metastatic disease. And I think there's a great object lesson for our country. I happen to have recently been appointed to the Congressional Budget Office panel of health advisors. One of the challenges is, and this will be the policy point 2, is that preventive services are only scored on a 1-year return. there's very difficult to get the full effect of immunization, substance use screening, cancer screening, and the like in a single year. And just a data point there, Melinda Bunton, Beth McGlynn, and others have published on the health services research literature when individuals are confronted with high deductible health plans, the first thing to go are the preventive services. And so while in the short run that would appear to save money, the truth is the insurance then consolidates the individuals with high risk. It undermines the concept of spreading risk amongst healthier individuals, and it moves more people from the healthy bucket to the less healthy bucket. And so for all those reasons, an economic argument for scoring prevention on a longer term.
Great. Thank you. I know many people in the audience will have questions, and we have a couple of microphones, so please go ahead. Yes.
Great questions. What's the perceived benefit to the clinicians and to the patients? And for many of the clinicians, they've come from paper to electronic health records, and it's not much fun. No one wants to go outside of their workflow to learn something, and so part of the reason that we've portalized things is that we want to get the information into the workflow, and we want to make the user interfaces much better. When you go to a professional meeting of internal medicine or the like, it's really staggering. All the instruments that used to be non-electronic, or not only electronic, but often digital. The stethoscope's digital, the ophthalmoscopes can flip off a digital image. Imagine a future where the health record sort of generates itself as a byproduct of actually going through the actions of physical exam. And so the opportunity changes from documentation to consideration of the meaning of what the findings are. Well, I envision a world, and here in Silicon Valley, I would love to see this evolution so that it becomes friendlier. The second is that we get the workflow in a way that, getting decision support on polyomics or the like isn't leaving the environment you're in. You don't get app to death by having to switch between a bunch of different apps to get this answer about what this constellation of molecular diagnostics means in this breast cancer patient, but it's part of the decision support, and that the system is just a whole lot more friendly. Well, in fact, we sort of challenged ourselves at HCA. What would a friendlier system look like? What would it look like if, in fact, it looked less like a tax form and more like an Amazon experience? So you're having an Amazon experience and ordering a heart attack. And, here's an anticoagulant. It's pretty high rated there. You see there are 4.5 stars there. And you see the light flashing, that there's some nursing recommendations in there, that maybe the nurse has some vital information, but the nurse has pinged you to pay attention there. And you see what some of the other folks who've ordered the heart attack have ordered. There are individuals who've ordered the heparin when in fact it's not been a heart attack, but a myocardial infarction, but it's gastritis, heartburn, in which case it's overkill. And there have been a few unfortunate episodes where it's been a dissecting aortic aneurysm, in which case the anticoagulation wasn't overkill, it was just kill, and very dangerous. So we want to make the system much more fun. We're looking at the gamification of learning. We'd like to see a sort of taximeter function for continuing medical education. We'd like to see it coherent so the decision support comes right back in to the interface. And we'd like to see it transportable so it works well on devices. Oh, by the way, we'd like exactly the same thing for patients as they can invest in their health information, their relationship to healthcare, and their providers through devices in much the same way, so that they can have very much a positive experience with that as well. And we've actually, just to be really clear on this, we've actually had to label some of our iPhones. We use a lot of iPhones in our organization. To deliver these things, that it says medical device, so that the patients aren't left there looking at, Dr. Perlin, I came here with a real serious medical question, and you're sitting there texting people. But we're not texting people, and that's why we've had to label them. And so we really wanted to be part of a coherent ecosystem of communication in the patient's interest.
Aetna getting bought out by CVS. Amazon, JP Morgan, and Berkshire joining hands to try to launch their own healthcare system for their employees. But a lot is going on. Vertical integration, multi-party arrangements. What's going on?
Well, let me just say for the record, I have no inside information here, and I'm looking to learn and coming to probably many of the same conclusions that you all are. First planning assumption is that our nation is facing a challenge with the sustainability of the cost of healthcare. Second assumption is that people are looking for higher value. Third assumption that traditionally healthcare has not been sort of meeting all the consumers' needs as humans, as individuals, even though we can offer very technically competent care. And so there is obviously a retailization. If you actually look at the flow of dollars after the Affordable Care Act, the additional dollars that came into the system went to a lot of places. One of the places they did not go is actually to direct patient care, particularly in high acuity settings. And so, as you look at the CVS-Aetna relationship, you can only assume, I assume, that it's a way to better manage the drug costs. And certainly on a worldwide basis, our drug costs in the United States are among the very highest. So that would seem to be a prominent part of the play. My own personal feeling, and I emphasize personal, is that the Amazon relationship also sees a retailization where there can also be reduction of the transaction costs in terms of pharmaceuticals. We as consumers are pretty comfortable now ordering stuff online. I want what I want when I want it is the itch that Amazon scratches. That would be a pretty convenient way to obtain pharmaceuticals, and one that will likely pressure for lower overhead than the current distribution mechanisms. I think there's some pretty interesting questions. It's not just that those three entities bring together, a considerable but not absolutely enormous base of employees, but they bring extraordinary skills, particularly Amazon, in terms of creating a market for things that maybe you didn't think there used to be a market for. A gig economy and the Uberization shows that you can actually have a market for lots of things, and it will be interesting to see whether you can order health services through an Amazon-like interface in the future, or if not you, your clinician or your insurer. So I think there's something there. There's something that's going to be majorly disruptive. Not exactly sure what it looks like, but it's a pretty potent force. And I'd be interested in your thoughts after the talk as well. I look forward to it.
How do we capture the social determinants of health or the psychosocial factors that may also be influencing wider health as well as what's happening in the hospital?
I love that question. How do we capture the social determinants of health? 80% of our outcomes are dictated not by what goes on in the care setting, but what goes on every place other than the care setting. We need the equivalent of meaningful use, the equivalent of high tech for public health. Across the 18,000 plus local health departments around the country, and some of you are simply too young to remember the technology, there are some that are operating on a technology called Lotus Notes. That's what they're using for their aggregation of data. We need to be able to have interoperable public health data, and I would argue this is one of the ways we can get under the increasing burden of chronic disease. It's one of the ways we can prepare ourselves and harden ourselves for both natural and man-made threats in the environment, and I would argue that the time is now to be able to bring them in. And back to the Dean's earlier question and comment, absolutely right that the mashup, the big data that we really want, is not restricted simply to the formal health environment, but those environments where the social determinants are really just that, determining the proximate and long-term outcomes.
Hi, I'm Matt Eisenberg from Stanford Healthcare. I work in interoperability and want to follow up on your discussion about interoperability and the one thing you would change from a policy perspective. I would also point out that we just talked about the vital directions articles from the National Academy of Medicine, one on interoperability and some directions for healthcare that I would recommend other people read. In one of the articles that you're the lead author, you talk about additional policy issues, a unique health identifier, national directory for exchange, beyond the healthcare financing reform. There are a lot of recommendations in that article. Can you comment on some of those?
Well, thank you very much for the question. Since I'm the lead author, I'm not sure if I'm still required to agree with all the recommendations. But the common health identifier would really simplify things. It's just a challenge. We can get pretty good by triangulating to who is who. But it is a third rail issue. And the triangulation algorithms are actually much better these days than they used to be. It is it is problematic that we have to go to a lot of machinations to find out and track an individual. The challenge that we have is that we're operating, for those who aren't really sort of deep in this particular sport, there are a couple different standards. One is called direct, and it's much more like email. You have to know who you're sending to before you can generate that email, and they have to know who you are before they want to send something back to you. And that's one standard. The other is much more like a web-based world, a world of services, a world of directories, where you know that Dean Minor is taking care of patient Perlin, and that he knows that I come from Nashville, but he doesn't know which hospital I've been at, and so can put a query out there in the same way that you would Google something. And with appropriate credentials, your query would be answered, that you could actually then find out that he's been at this facility and this primary care provider and this pharmacy and these medications and those allergies. And so this is the really exciting next step. And just at this very moment, there is something called TECFA, but it's a Trusted Exchange Framework Plan. And the debate that's going on within that is the world going to go to direct, or is the world going to be more like a web-based environment, or both? And some of the underpinning questions are the technologies to create the interfaces robust enough to really get to that environment? There's a set of standards that are enticing, wonderful, but incomplete, called FHIR, Fast Health Interoperability Resources. And they may provide the ability to tap into different pipelines or systems of information, create that web services capacity. So pretty excited about that, but we want it to work in a way that is rational and friendly, and again has reasonable workflow and it's not overly burdensome. And oh yeah, by the way, has to fit into a public sentiment that's much more attuned or concerned about privacy than probably the derivative of interoperability, the ability even for last mile care, or certainly the learning. So I think in addition to our technological challenge, we have a social and policy challenge, and we need to really sort of illuminate the value to both the end users, the patients, providers, as well as policymakers, and certainly appreciate your work in that regard.
I think we have time for one last question. Yes, sir.
The way to look at it from each of these angles is that entrepreneurs look at the health system as a very complex way, and the clever thing is like how to navigate it, how to find an idea and like a way, like to be able to build something and like innovate and get through, like all these privacy and regulations issues. So what is your advice on this, and like on how to navigate it well, or how to learn how to navigate it?
Great question. How for entrepreneurs to navigate a system that's so complex and has such regulatory burdens? I am absolutely certain that the most disruptive innovations in health technology will come from entrepreneurs and individuals and startups for a couple of reasons. First, when I had the privilege of chairing the Health IT Standards Committee, in addition to that last mile interoperability, my other goal was to create handholds or APIs, programming interfaces, so that the formal systems could be used by entrepreneurs to tap into in a robust ecosystem of health information that got not only to be sure about this at the formal care settings, but at the public health settings, and allow us to address the social determinants. The second piece is that I think you have an inherent advantage, which is that for those of us who come from the formal health environment, when we look at a problem, despite our desire to be sort of free from the constraints that we appreciate are out there, we tend to look at that environment with an eye to all the regulations that limit the possibilities of what we can do and thereby narrow what we might seek to do. I think it's so interesting to see entrepreneurs in the health space who look at 20% of the economy and look at the shortcomings that exist and say, and don't look with the regulatory blinders, but instead look as optimists and innovators and say, I know how we can solve this problem. And so I think that fundamentally is the opportunity. Some of the technologies I've talked about today that have actually become mainstream are technologies that began just that way. The ability to create this type of consumer experience for health clinicians, a company in Boston called Patient Keeper, bring the information back to nursing, a company called Mobile Heartbeat, which had said, why, we understand you need secure texting. You don't want people using regular text. How do you bring that in? Digital reasoning is the power behind what I demonstrated in terms of the cancer patient identification and the incidental findings. And what I think is so valuable there is that the big stalemate point for bringing together data science and healthcare, similar issue, by the way, in defense intelligence, is that the traditional mechanism for ingesting the data gives all the intellectual property and all the protected health information to the purveyor of the data science. What if you could actually split the model off from the training of the model and have an app instead? And that was something that was solved by digital reasoning outside of this context. So for all those reasons and with some tangible proof points, I think this is a time to be really excited if you're an entrepreneur in this space. And don't fall prey to all the barriers that we see, and we look out at the world, but look at the world, with the opportunity that that can occur. I mean, it's really maybe it's the note to end on is the great Robert Kennedy quote. Some people see the world as it is and wonder why. Others see the world as it might be and ask why not. So fall into the latter camp.
Great. John, thank you very much.
Thank you very much. Thank you all.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.